in 2017, the Association for SP Educators created the first standards of best practice. They are being revised now, and very soon, hopefully, will be published, the second edition of standards to work with standardized patients or standardized participants. I forgot that AAMC, the American Association of Medical Colleges, convened a conference, a consensus building conference in 1992, where it was really established that SPs are valid and can provide reliable case portrayal and evaluations. So SPs are a teaching tool, but we have to consider them as educational specialists. And in that way, we don't want to talk about using SPs, but we want to refer to working with SPs. Some people in the field are very sensitive about not using the term using SPs, because we want to have them be educational partners. So here are the here are some of the tools that we have to assess, to teach, assess, and also research skills as opposed to knowledge and values. So often programs start with lectures or small group discussions or computer-assisted instructions. And that's where it's a good opportunity to instill some core knowledge and values. Then often programs provide virtual patients as an opportunity to start dealing with clinical reasoning. And there are many online programs for that. And then we have the SPs, standardized or simulated participants. You okay? Then we have the simulated or standardized participants who with whom learners can practice history and physical exams, counseling, but also teaching and teamwork. It's not just patients that are involved in human simulation. Everything okay there? Okay. So afterwards, they may be more ready to work with mannequins and task trainers to learn specific procedures. And in the end, they can work with real patients. And the benefit of going through all this human simulation and all the simulation in general is that patients will be safe, safer, less likely there would be mistakes that they could harm them. And also for the learners, it's very nice to feel more confident about their skills level. And so they will be able to work with patients in real environments in a much more confident way. And also what we have often is a combination, hybrid simulations, where it's not just the SP, but they're working with other elements of the simulation spectrum as well. So some current trends. So if we start out with recruitment, so who do we need to recruit to be a human simulator? How do we train them? Where will they perform? And the quality improvement is always important whenever we work with simulation. So starting out with recruitment, diversity is a topic that has been very much on many people's mind because patients are diverse and healthcare providers are diverse. So we need to pay attention to that. And so this diversification created a lot of new scenarios. And so also we have to pay attention to who will be the SPs who are working with those scenarios. So the disability community created this mantra, nothing about us without us. But in simulation, we don't always have or don't always want to have somebody who is actually experiencing all these challenges that many people have, for either because they have a disability problem or for other reasons they may be disadvantaged or disenfranchised. So in many OSCEs that I work on, have worked with simulated patients, standardized patients, and there are some culture OSCEs. And so we need someone to portray a Bangladeshi patient, parent, it's in pediatrics actually, or a Nigerian recent immigrant. And so none of the people you see here actually have that background, but we need to, with prompts and with making sure that they can mimic an accent, we can make them real enough to portray these cases. I also have been working with children in OSCEs, and we have a case over the many years. We always had a case of a 7-year-old boy or girl. And as you can see here, there were a number of children who portrayed this scenario, but they were all much older. So we don't necessarily need a 7-year-old to portray a 7-year-old, but we need people who look young, children who look young enough that they can go for this age group, that they can be considered this age group. Okay, so props, moulage, wearables, they're all very important with human simulation as well. And I may have shown this at a previous presentation sometime, but as you can see here with the white coat and the stethoscope around the neck, you can make somebody look very clinical, very professional. On the other hand, if the person is wearing a patient gown, then he will be more likely immediately identified as a patient. There's a lot of moulage and wearables also that become part of our human simulation scene. And this is an example from Ireland, actually. You can see here in the back of the picture is a 3D printer. And this studio that they have as part of the simulation center is producing a lot of moulage and other wearables, as you can see here. There are also many companies who provide these kind of tools to make a simulation look more real. So you can see on the left side is the real person who is quite slim, but with some additional props and some wearables, she can be made to look like she's having a weight problem. So there are many ways that are developing to make the simulations as realistic as possible without actually using people who have those characteristics. Now moving on to... Next, we will address the issue of technology. Oh, which I don't know what this is, but it's my voice. I tried to efforts. I maybe have not eliminated the sound here, but this is about training. So the key training topics that we need to always attend to when we work with human simulation is the content. So what should they say or what should they do? The emotional tone, how should they say it or how should they carry themselves? And the timing, when should they do it? And there are more recently, as you can see, an effort to provide a spectrum of stringency, of the level of stringency for different types of simulations, human simulations. So from role play, which may have very little standardization, to more structured simulations, to very high stakes exams. The level of stringency, of standardization will vary. And that's something else we need to keep in mind. Not every SP is able to be as consistent And so finding the right SP to be able to do the work that's needed is important. So what kind of training could be done in order to, instill the case portrayal, evaluation? Many SPs also have evaluation responsibilities and feedback. So there's in person, of course, we have been doing that for a long time, but with COVID-19, a lot went online, and certainly these types of training can also be very easily done in many cases online, especially if it's mainly about communication skills, getting a history, and also counseling, for example. But also more and more programs, and also the Association for Standardized Patient Educators is developing different modules that are online, where the SPs can go to learn some of the skills that they need and some of the knowledge that they need in order to be effective SPs. And more recently, there have been, of course, for training communication skills for healthcare providers, avatars that can be where one can practice communication skills online. And the same is really true for the SPs. They can also learn that way. What kind of questions could they be asked? How could they answer it? So that's a possibility. And then another one below that you can see is a hologram. That is another newer tool where you can see in that box, it's a hologram, and the person will respond back as if it was a real human being. So it's another way to practice dealing with a learner, for example, who will be asking different questions, and the SP needs to figure out how they will answer consistent with the case. Okay, moving forward, the settings. There are different settings, and you may have noticed this one, may have seen this one here, because it is from TUMS, from the Simulation Center. And so it may be in a simulation center that the simulation will occur. It could also be in the hospital setting. Or sometimes simulation centers have rooms set up like a hospital. Also, an OR is possible, and that's also in many simulation centers, but could also be in a real setting. Telephone stations or telephone encounters can be also important. And sometimes there's a need to teach about home-based care or home visits. And so some simulation centers also have a setup like the one here, where learners can explore what would be hazards for risk for falling, for example, or also how could you manage to do your clinical task in a setup that is not a clinical one. And of course, on the top, we can see some other simulations where SPs are involved in a mass casualty event simulation, maybe outdoors somewhere. But in all these places, think about how will it affect the SP to be working in those kinds of settings? What kind of, feelings and could they instill? What kind of challenges could they experience? One other thing that is important to keep in, that is becoming more and more popular, is immersive simulations. So you can see here on the left, there is a room that has video screens all around, or most of the walls, and it will provide an environment that is not in the actual simulation center, but it provides an environment where the simulation would be taking place. So the effort is to engage as many senses as possible. So sight, touch, hearing, smell. Also in some nursing programs, they are utilizing some ways to engage learners in when there's vomit involved or some other way that they need to manage in a real life setting. So also sound, and here I'm just going to very briefly give you an idea. Imagine you are working on an ambulance and you are rushing with a patient to the hospital. And so you may get these kinds of sounds, and think about what it's like for the learner to operate under such conditions, which are real life conditions, but also what it would be like for the human SP to portray this case in an effective way. So just very quickly, I hope it's not too loud. I hope you can hear me. But this is what the real life situation would be. And this is really what we are aiming for. We want to make it as close to reality as possible, even though it's a simulation, because we want to help learners transfer the skills that they're practicing here to the real life situation. So also another issue is that we know that people, when they know they're being observed, they may not perform optimally or the way we hope they would. So there has been more and more involvement of unannounced SPs or USPs. And these are SPs who are sent into real life clinical settings and or educational settings, and they are will portray the case as they are taught in a standardized way, and then they can also report on what has been happening in that setting. So to make it fair to the learners or to the people who are being observed, they are told that there will be there's a certain time frame when they will get one of those unannounced standardized patients or unannounced standardized participants, and but they won't be told ahead of time. So there is an increased chance that they would behave as they would in a real life situation. It's difficult to set up something like that, but it's used more increasingly as a teaching tool, as well as an opportunity to assess learners and provide feedback afterwards. And also it has been used for research to see whether some training program for continuing professional education, for example, whether that is also being carried out in the real life setting. Okay, so moving on to quality improvement, it's important for everything, of course. And here is a formula for evaluating SP performance, which is exactly the same as we are using for evaluating learners. So performance is then the function of skills and knowledge, the skills and knowledge they have about the case, for example, but it's also affected by motivation. Are they really motivated to to portray the case consistently? Are they interested in helping the learner improve? What is their motivation to engage as a human simulation, SP? And there's also the opportunity, because it is possible that one of the learners goes off in a completely different direction, and then there will not be an opportunity to maybe portray the case as initially scripted. So there are different factors that we need to consider when we evaluate the SP performance, but maintaining, keeping track of how it's going is critical for any SP program. So finally, we mustn't forget that human simulations are dealing with humans. And so there are some cognitive factors and some emotional factors that need to also be considered. So in terms of learning the case, we need to think about cognitive overload, that if there are too many details, the SP may not be able to remember them effectively. And we need to pay attention to that. Also, since they're human, they are biased. We're all wired for biases. And so as part of the training, we need to try to bring them out and try to eliminate them as much, neutralize them as much as it's humanly possible in order to make this a fair learning experience for our trainees. Psychological safety is also very important. Being an SP working under some difficult conditions sometimes is very stressful, and we need to be careful that they feel safe enough to portray the case. And there's always a potential of a burnout that we need to watch out for as someone who is organizing human simulation programs. Also, personal experiences. They come to the simulation having their own personal experiences, and we need to be careful that the experiences they have as an SP doesn't trigger some personal trauma that could be, that could result in some personal trauma that is triggered some past experiences. So support for the SP is always critical. Debriefing them is critical. And yeah, it's not easy, but it is important. It's a very important opportunity for learners to have to work with someone who is there to portray cases they will see on afterwards in real practice. So with that, I would like to say thank you to all for your attention, and I'm very happy to answer any questions you may have. Thank you.
Excuse me, dear Mandana, we don't have your voice. Your microphone is off. Please turn it on. And yeah. Dr. Shirazi, do you have my voice?
Yes.
Yes,
And,
yes.
is there any questions? I'm asking participants if they have questions in this regard. Dr. Mirzazadeh, could you please help
Yes.
us in this regard?
Dr. Shirazi, Dr. Karim is now here. Yeah, we have Dr. Karim. Yeah, Karim is now online. Yes.
Okay.
Okay, we can hear the question of Dr. Mirzazadeh. Sorry.
Yes, please. So,
sorry, Elizabeth.
thank you very much, Elizabeth.
Elizabeth, good afternoon, good evening, morning for you, and good afternoon for us. How are you?
I'm fine, thank you.
Yes, thank you. Thank you for sharing your experiences, also wisdom about the simulated patients. But at the same time, two points I would like to raise about your presentation. One, about the role of SPs as providers of the feedback, and to close the circle and cycle of debriefing and some sort of helping the students to learn by the voice of the patient and by the perspective of the patient. And the second point, the challenges about the standardizing patients and how we should do that, because one of the major challenge for us is we are doing that, but Yeah, especially for high stake examination, it's much more difficult, especially when we consider, for example, an examination nationwide in many universities and many ASCII centers. Thank you.
Oh, thank you for the questions. Yeah, feedback is very important, and it's really an unique opportunity to have somebody who is experiencing the encounter to provide feedback. It does need some training for many people who don't know exactly whether they should just be nice or how they can communicate that things could be done differently. So having some training sessions about giving effective feedback is important. And really all the critical elements of effective feedback are important here as well. You know, they should be specific. It should relate to what happened. It should be related to behavior that can be changed. It should not be about any characteristics the person may have. So it's something that needs practice as well. Sometimes SPs give written feedback that can also be very helpful to provide some documentation afterwards of how they experienced the encounter. But it's really would be a big loss not to have them provide feedback. Even children can provide feedback, and you know, having shown that case before, you know, the talked about this before, it was always very powerful for the pediatric residents who were in that station to hear from the child that they felt left out, or that they felt that they were only talking to the mother, they weren't talking to the child. So it was much more powerful to hear that from the child than to hear it from a faculty member observing. So I think human simulation feedback is critical, and not using it is a waste. So much for that. The second one is how to standardize. So there's a lot of discussion about standardization. Obviously, the point is that we want to give every learner the same opportunity to perform skills that we want to evaluate. So there has to be some standardization for that purpose. But it is more than just saying, but one of the criticism that has developed is that the standardization went too far on some of the licensing exams, that it was, they were just giving single word answers. And that is not really normal in many cases. So it moved away from it being realistic and just checklist type evaluations. You know, did they ask this? Did they ask that? Did they do this? Did they do that? But it was not, it's not so dynamic as one would encounter in a real world. So finding the right balance is difficult, but it is important. It's definitely more, it's definitely better to have a human simulator rather than a real patient who has no understanding that they are there for educational purposes or for their assessment. So their mindset may be very different. And when you have a SP, you make them part of your team so that they understand what the objectives are, what the goals are of the exercise or the exam, and they can feel they're contributing a very important element of the training. Does that, is that sufficient?
Thank you. Thank you so much.
Okay, you're welcome.
Thanks a lot, Elizabeth, for your nice presentation. And hope to see you again in another webinar or in real world.
That would be lovely. That would be lovely.
Bye. Bye.
Hello, everyone. Karim, do you hear my voice?
Yes, I do. Yeah.
Yes.
Okay, great. Thank you. It's great to see you again. How are you?
Oh, okay, surviving. I was on the plane all night because my plane was late, so I didn't sleep much. So that's okay. I'm here.
Okay, great. I want to start with your short biography so that our audience know you better, and then the stage will be yours.
Sure. Thank you.
Good afternoon, everyone. We're going to listen to Dr. Karim Qayumi. Karim is Professor of Surgery in the Division of Cardiovascular Surgery at the University of British Columbia, Canada. He's the founder of the University of British Columbia Center of Excellence for Simulation and Innovation, Chair of Technology-Enabled Learning for Vancouver Coastal Health, and Regional Director of the Royal College of Physicians and Surgeons of Canada. He is a member of accreditation committees and innovation technologies committees for both the American College of Surgeons and the Royal College of Physicians and Surgeons of Canada. He has extensive international teaching experience and an excellent record. He received 11 awards in the field of medicine, including the prestigious Killam Teaching Prize from the University of British Columbia. Dr. Qayumi has conducted various research projects, including heart-lung and combined heart-lung transplantation. Recently, his focus has shifted to technology-related research and innovation. Among his patents and innovations, the development of technologies such as the artificial intelligence interactive multimedia software called CyberPatient, an online learning management system named Electronic Platform for Education and Research, or PER. Robotics for telehome care and patient-centered medical records are considered exceptional. He's well published with peer-reviewed papers, 135, abstract 70, and he has presented 200 keynote speeches. He also serves as advisor and consultant to many national and international education and healthcare organizations, and he is an expert on the board of directors and advisory board of many universities, companies, and nonprofit organizations. He is founder and president of Canadian Virtual Medical School, which is the first virtual medical school aiming to revolutionize medical education through innovative teaching and cutting-edge technology. Karim, the stage is yours. We're going to listen to your presentation. Thank you.
Oh, well, thank you very much, Shoaleh, for a very extended introduction. Really appreciate your thoughts. Let me share my slides first, right, for you.
Okay, great.
Okay, well, let me see. Well, dear colleagues, friends, ladies and gentlemen, first of all, I would like to extend my appreciation and gratitude to the organizing committee of this wonderful meeting, particularly to Dr. Shirazi and my longstanding friend, Shoaleh Bigdeli. I have been asked today to talk about the Canadian Virtual Medical University. So by the end of this presentation, you would be familiar with virtual medical education. We would be familiar with the curriculum design of the Canadian Virtual Medical University, the curriculum implementation of Canadian Virtual Medical University, present status of Canadian Virtual Medical University, and then we talk a little bit summarizing the whole thing. In relation to the need for virtual medical education is very obvious. According to the World Health Organization, by the year 2030, we're going to have 18 million less health force. And from that, about 4.3 million are physicians. In this gap in physician deficiency is much worse in developing nations, and particularly in conflict zones. Therefore, the United Nations Sustainable Goal clearly says that it's important to have inclusive, equitable, and high-quality medical education with lifelong learning opportunities for all human beings. Now, this huge deficit that will be by 2030, 4.3 million doctors in the world would need about $4 trillion in 5 to 10 years to build a new medical school and solve this problem and fill this gap with traditional medical education. And as you and I know, it's practically impossible to raise that fund or to wait 10 years to build universities. Therefore, the notion of virtual medical education is becoming more and more important in the world. So the innovation solution we propose is to actually change the curriculum design from traditional into the virtual, which would be mostly a competency-based, student-centered curriculum. And the content, of course, is not going to be different, but is going to be packaged differently. So I will talk about that a little bit later. And then the delivery method, we have to use state-of-the-art technology to support not only theoretical part of medical education, but also the practical aspects of medical education. So now that we know a little bit about the needs assessment, I will talk about the curriculum design we have. Perhaps you all know much better than I do about the definition of the curriculum, so I'm not going to spend time on that, but I will promise to spend some time on the difference between a traditional medical education and a virtual medical education that we propose. So if you look at this table, I tried to bring the 5 important pillars of a modern curriculum, which is learning objectives, content, method of delivery, method of assessment, and evaluation. So with respect to learning objective, in traditional curriculum, learning objectives are defined by instructors, and mostly it's knowledge focused. In CVMU curriculum, it's defined by EPAs, that stands for Entrustable Professional Activities. So the EPAs are the unit of knowledge, and it's aligned with competency milestones and practical tasks. The content in traditional medical education is subject-based and is organized by disciplines. And the Canadian Virtual Medical University curriculum, it's competency-based, and the units are EPAs, Entrustable Professional Activities. So the methods of delivery for traditional curriculum is basically lectures and in-person teachers, teaching is led by a teacher. And our curriculum is a bit different. It is because it's student-centered, so it's based on assignments, and it's delivered asynchronously. And the end of the every week we have seminars through Zoom or other technology. So assessment is also in traditional medical curriculum is mostly summative. It's written through OSCEs or MCQs in other type of examinations. And the formative assessment, which is the most important part in the modern pedagogical theories, is not really done properly. As a pedagogue, I can tell you that in a rotation of 1 month in a hospital, nobody is able to do more than one formative assessment. Even that is sometimes difficult. Mainly it's because it's manpower driven and it's very difficult to do. So in our curriculum, the formative assessment is the center of everything, and it's done weekly. So we have weekly formative assessment. And in the end of every EPA, we have then summative assessments. And we have a pre and post test to see how they improve. And evaluations are usually done by the end of each rotation or by the end of each semester. Our evaluation is all online and it's done also weekly in the end of each weekly seminars. In addition to these differences in the pillars of curriculum design, 3 other factors are also important to mention here. One is the student role. So in traditional medical education, the student's role is passive, and the students are recipients of knowledge. Wherein in our curriculum, the students are active participants and is self-directed. So they're running the show. That's why we call it student-centered. The other thing is equity. We all know that traditional medical education is for the specific region, and you cannot, it's difficult to expand it to other regions, or to the other part of the world, it's much more difficult. And it's designed for people who has money. In any country, you see, in any developed country, 80% of the students are from rich people because they can afford. Our curriculum is open access, and it's designed for underserved in conflict zones. It is free of charge, and it's asynchronous, and we can deliver it any part of the world we want. And the cost of medical education is very high, as you guys know. In the United States and Canada, it's about $120 per year per student. It's just the tuition fees. But in other less resource countries, maybe $20,000 to $50,000. But nevertheless, the cost of our 1 year of our student is 90% less than traditional medical education. Now, we talked a lot about the EPAs and as a unit of education. So here is a simple design of our curriculum on EPAs, entrustable professional activities as a unit of competency-based education. So students start to enter the EPAs, and we could have 3 different types of EPAs. We have core competencies, APAs. We have skill competencies that would include procedural skills and a clinical skill, in concomitant competencies that I will talk a little bit later about it. It's mostly longitudinal curriculum that are not core subjects, but the students should know, such as pharmacology, epidemiology, immunology, scientific method, medical ethics, CanMed competencies, and things like that. So each EPA is then divided into smaller portion that's called functional competencies. And then each functional competency divides into much smaller units that's called milestones. So the learning objectives lies into each of those milestones. And then we identify whether these milestones are psychomotor, affective, or cognitive. Students completing the milestones, through the formative exams weekly, as I mentioned before, then they go and complete a functional competencies, and then go into an a summative assessment for an EPA, and they finish this EPA, then they go to the next EPA and next EPA. So the whole medical curriculum is divided in 4 levels. Why we are saying levels is because we don't have time. There is no time, there is no semester in our curriculum. Students can come at any time into the system and can do it as fast as they want to do it, or they can do it as they're able to do it. So in the level 1, we have about 9 core EPAs that includes mainly foundational knowledge, and it's a system-based APAs such as for anatomy, physiology, biochemistry, things like that. In level 2, we have another 9 EPAs, again system-based, for pathologies. And then in the level 3, we have another 9 EPAs, core EPAs, that are mostly divided into 5 important rotations, which is internal medicine, surgery, OBGYN, psychiatry, and pediatrics. And level 4 is actual transition from virtual into the real environment. It's internship. So level 1, 2, 3 all delivered to their homes. And once they pass the level 3, then they go into the hospitals and clinics to apply that knowledge into real life. In addition to core competencies you see in green here, we have slowly increasing the scale competencies, which would include, as I said, both procedural competencies and clinical competencies. And we have 12 concomitant EPAs on the site. So now that we are a little bit familiar with the design, we talk about the curriculum implementation. You perhaps remember, as an Afghan, I can say that December the 20th, 2022 was a dark day for Afghanistan. It's not that Afghanistan didn't have another dark days, but this was the day when the government of Afghanistan eliminated female from going to school, and about 8,000 female medical students were, deprived from medical education. This was actually the moment that sparked the light in me to do something about it. And I start thinking the only way I can help these girls is to design a student-centered competency-based curriculum that I can deliver medical knowledge to their homes. And it took about 1.5 years for me to redesign the knowledge, the basic knowledge, which is the same for in traditional medical schools, to repackage it and redesign it into specific EPAs. And in 2004, I went to the government of Afghanistan, talked to the main people like ministers and deputy ministers, and they were saying that, okay, that's a good idea, but this is something new. You have to do the proof of concept with our students and our teachers. And we did that, and in April 2024, we delivered our curriculum to 105 students and in 8 medical schools in Afghanistan. and the results were outstanding. So we discovered that the knowledge in competencies and procedural and scale competencies improved significantly with a p less than 0.001. And then we also found that working with cyber patient, our online platform, their diagnostic skills are becoming better, and significantly they could do faster diagnosis and treatments of a patient than comparing to the pre-assessment. Also, we did a survey and find out that most of the, more than 90% of students really like the program. And all this was published in the Journal of Lancet Discovery, eClinical Medicine, and you're welcome to go in and get it and read the details of the protocol and everything else. So the present status of our university right now is moving every day. As per information I got yesterday, we have about 250 Afghan female students, and we have 30 instructors. Actually, we have instructors from all over the world, from Canada, from Europe, from Argentina, from Iran, from all over the world. And we completed the first term about 8 months, and during this 8 months, we did a rigorous assessment of performance pre and post test for knowledge skills, and also did a survey. And the results actually repeated. It was the same as we had in the pilot project. In the pilot project, we had only for cardiovascular system. Here we have, in addition to cardiovascular system, you had respiratory system, digestive system, musculoskeletal system, and also nervous system. And it shows, in comparison to pre, it shows significant improvement in each of those knowledge base. And then we did the survey and find out again that 90% of girls also like the program and how they study. They're very enthusiastic. So we took the knowledge gain that they have in skill development, and also the learner satisfaction, did a triangulation of the data, and we found that a nice conversion showed that indicate that the curriculum is both statistically effective and experimentally valued. We also took the results of the performance of students in the previous study, in the present study, to look at the validity, and we did have a very strong construct validity and external validity as well as internal validity. Now, in summary, I can say that CVMU at present time, it's more than a university. It's very difficult to imagine that a bold idea in Afghanistan has become a proven model and accessible, high quality virtual medical education that aligns with the United Nations Sustainable Development Goals. In the levels North American standard of education, 90% cheaper to anybody around the world. Today, we have this curriculum. Beauty is that it is scalable and it's adaptable to cultural values of different nations. And today we have students from Sudan, we have students from Ethiopia, from Somalia, and from Yemen. We are trying to get students also from Ukraine and Gaza. So in conclusion, I can say that it is a revolution. It is a movement. It is not just education. It's a lifeline, illuminating pathway of opportunity through innovation and compassion. I would like to thank you again for listening to me the old man. And if you have any questions, I will be more than happy to entertain. Thank you.
Appreciate your wonderful presentation. Is there any question? Any question about Canadian Virtual Medical School? Yes, please. Could you please come here? Okay, okay, go ahead and listen.
Good morning, Professor. Thank you for your good presentation. My question is, do you have any experience on actually on this medical virtual school on public health, for example, training elderlies on self-care?
On public health issues?
Yes.
Yeah. As I mentioned, the public health is part of our concomitant EPAs. And all our students goes through those EPAs. Yeah, epidemiology is part of that. Yeah, if that's what you meant.
And how can we actually learn from your experiences? Can you give us a pathway to find out how you have been in your actually in your medical virtual school communicate with in public health with people who are needed for kind of education that they cannot afford from hospitals, or for example some settings that they need to go and ask for this actual education?
Well, at this point, we don't have a specific course for public health, but the public health EPAs could be taken by anybody. It's not, we were open to anyone. And again, the important thing here is to in that context, to support other medical schools or, you know, health schools who wants to do these kind of activities, so we could support them. I didn't talk a lot about the methodology, methods of delivery. Our methods of delivery that revolutionizes the medical education, actually, it's the skill competencies that we are able to deliver virtually. The rotation, so we can do now the you know, all the rotations that I mentioned to you before as a clerkship rotation, we can deliver this virtually. Is because we have the technology, we have cyber patient. It's a very extensive platform that is it's a virtual hospital with 190 patients. That these patients are with different diseases and different conditions. The student can go there and do whatever they can do in the hospital. But the difference is here that the patient, if you make a mistake, is not a problem. So you can practice without ethical or legal consequences, and you would learn because the AI will support you to do. You have also in this platform communication skills, how to deliver bad news to a patient, how to transfer patient from one ward to another ward, how to hand over patients from in an emergency room, how to do consent forms. So we cover all aspects of the practical clinical skills, and that is the power behind it. With respect to theory, we use Lactario, which is a very sophisticated, perhaps you're familiar with, you know, sophisticated platform. So for theory, we use that, but for practical skills and competencies, we use cyber patient. And if you like to have some cases of epidemiology, you get in touch with us. We can make those cases for you to support your population.
Thank you for guidance. Thank you so much. Bye.
Karim, there's another question. Azim is going to ask his question. Yes, please.
Dear Dr. Qayumi, thank you so much. Really fantastic. And as you mentioned, it's not just university, it's a light in the end of a tunnel for those people who are in crisis. And thank you for your approach to such a real problem for all the people around the world. I was going to ask a question about the clinical phase of your curriculum. And as I realized, you mentioned that the clinical phase would also be virtual. And I know about cyber patient platform and the richness of the patient mix over there. And as I heard, you added the AI to it because one of the major challenge in cyber patient was that the questions was prefixed and the answers was prefixed, and therefore the students couldn't ask their questions, but they just should select some questions. It's not the real practice of a physician. But the major issue for me is that, as you mentioned, in cyber patient, the student couldn't harm the patient. I know that the medicine is not about to harm, but one of the reasons that we reach the professional identity that we should have is that if we make mistake, the patient will suffer some pain or some consequences. And therefore, do you believe that just virtual training and virtual clinical training is sufficient? I just understand the situation, for example, in Afghanistan or Gaza or Ukraine, and therefore I 100% agree with you that we need such a platform to help them. But is it sufficient to let students to be graduated and to ensure that he or she is competent in EPAs? And the next point is about the practical procedures. For example, I'm not sure, but it's so strange that the cyber patient currently with haptics could simulate the physical examination of the patient just on the patient, not just on the screen, or asking some questions and wanting to know something about the crackles in the lung, and we could hear it or not. What's your idea about these challenges of the clinical phase?
Yeah, so thank you very much for your question. That's a very good question, but I think there was a little bit of a misunderstanding. Maybe I was not very clear about it. If you remember, I show 4 stages and 4 levels, and level 4 was internship that is happening in the clinics and hospitals. So
yes.
So what we are replacing is the clerkship with virtual education, not the internship. I strongly, personally believe that even not, we don't have to look into the advancement of technology as a haptic, because we may have to wait another 50 years to bring that into the virtual education. But clerkship, actually, I don't know about in Iran, but if we look into ourselves clearly and honestly, no student clerk would go and do a procedure. Would you allow a clerk to do a procedure? No, you are observing. You're observing in the hospital. The clerks are the last people on the line after the chief resident, second, 4-year resident, 3-year resident, 2-year interns, and then there is this clerk. So for clerk running around like a headless chicken inside a hospital, from my perspective, is a myth that they would learn better than the virtual environment. they can see in the virtual environment and sharpen their clinical skills and procedural skills by watching 1,000 times the same procedure up until they get it. And in watching and observing in the screen of a computer or behind the shoulders of 10 people is exactly the same, or maybe even better, because here you have the opportunity to intervene, to think, to watch it again and again up until you learn. So we're not proposing to make a virtual environment doctor and let them go into practice. So what we are proposing is that it's time to use technology for our advantage of medical education and actually do a real clerkship in a virtual environment before they go and touch a patient. And of course, they have to do the same rotation for the whole year, again, in the real hospital, in the real clinic. It's like, I'll give you an example. Would you sit on a plane if you knew that the pilot didn't have thousands of hours of simulation? No, but why a patient should? And with respect to the medical errors, I have to tell you, this is not news. Medical errors are the third killers in North America after coronary artery disease and cancer.
Yes.
Medical errors is the third killer in North America. It's not about some pain. It's about killing people. 12% of patients who come to the hospital, they get hurt by doctors and nurses. And 2% of them die. It's more than even traffic accidents on the road. So it is a problem. It's a pandemic. I'm not saying all these are because of our students, no, but immature doctors, immature nurses, and health force work, is responsible for this. And the more they do simulation, the more they learn in the lab or outside. It's not just virtual simulation. They can do the beautiful presentation was done by Elizabeth on other type of simulation, the SPs and others. So physical simulation. So to learn, when we talking about the skill, not theory, we're not talking about transfer of knowledge. We are talking about transfer of learning. So transfer of knowledge from one person to another person, but transfer of learning is from the same person to the same person, how our previous experience affects our present experience. In Chan, it's the Hofding's theory that is very old, but Chan in 1980 made this theory clarified that we have 4 stages of transfer of learning. And the first 3 stages can be done in a laboratory outside the patient. And then they will be ready to go and do better clinical work, faster. Right now, what we do with our even interns, we don't allow them right away to do things. We take their hands slowly, moving, making sure that he's not gonna make mistakes, right? And not gonna harm the patient. But what it does, it makes it very slow. The education is slow and efficient. So what the word of simulation, what we are proposing is that simulation, not to replace clinical practice, but to be a precursor of clinical practice, to be ready to make students more ready for clinical practice. I hope I answered your question.
Thank you. Thank you so much.
A very interesting discussion, but unfortunately we have to finish up the session because the next one is going to be conducted and we are a bit late for that. And I suggest all our audience to be in touch with you via email if they're interested to continue the discussions.
Sure.
Appreciate your presentation and it was great to meet you.
Thank you.
Thank you. Bye. And thanks, dear Elizabeth. Bye. Thank you. Bye.
Bye-bye, everyone. Very
Bye.
interesting presentation about the Canadian project. I hope I learn more about it. Okay,
Thank you so much. Thank you. Bye.
take care.